Welcome to my channel, Chemo Pharmacology 101. My name is Lisa and I am a board-certified oncology pharmacist. Today we will be talking about Irinotecan. As a refresher, the cell cycle is very important when learning about several chemotherapy drugs. During the G0 phase, it is a resting phase where cells are not actively dividing. During the G1 or gap phase, the cell grows and increases in size to become ready for DNA synthesis. During the S phase, DNA replicates. During the G2 or gap phase, the cell grows in anticipation of division. And during the M phase or metaphase, a complex series of events results in chromosomal separation and cellular division. Irinotecan acts on cells in the S phase where DNA is replicating. Topoisomerase 1 is an enzyme that relieves tension and supercoiling of the DNA by creating temporary transient single-strand breaks, otherwise known as the cleavable complex, during DNA replication. Irinotecan and its active metabolites stabilize this temporary cleavable complex and prevents religation of the DNA. This leads to single-strand breaks and DNA supercoils. Because of the prevention of religation, the replication fork collides with the cleavable complex and creates single-strand breaks and leads to supercoils ahead of the replication fork. There are two formulations for Irinotecan IV, including regular IV Irinotecan as well as liposomal IV Irinotecan. Traditional IV Irinotecan is FDA-approved for metastatic colorectal cancer. It is an IV infusion and is typically infused over 90 minutes. The dosing schedule varies based on the regimen and indication. You may also see it be used in many off-label indications, such as in pancreatic cancer, Ewing's sarcoma, cervical cancer, non-small cell lung cancer, and unknown primary cancer. Liposomal IV Irinotecan, otherwise known as Onivyde as its brand name, is FDA approved for patients with metastatic pancreatic adenocarcinoma in combination with fluorouracil and leucovorin after progression on previous gemcitabine-containing regimens. You may also see it be used off-label in metastatic progressive biliary tract cancer. It is also an IV infusion given over 90 minutes every 14 days. Pre-medications are required because Irinotecan is considered to be moderately emetogenic. Moderate emetogenicity means that 30 to 90% of patients would have nausea and vomiting without using pre-medications. It is recommended to give patients a 5-HT3 receptor antagonist as well as dexamethasone approximately 30 to 60 minutes before each dose. It is also recommended to consider giving patients prophylactic atropine to prevent acute cholinergic diarrhea. Irinotecan is hepatically metabolized via CYP3A4 as well as via carboxyl esterases. It is converted via carboxyl esterases to SN38, which is the active metabolite, and via CYP3A4 to APC, which is the weak metabolite. SN38 causes the most cytotoxicity as well as other acute toxicities. SN38 is glucuronidated via UGT1A1 to SN38G. SN38G is then excreted via the biliary route, and then bacterial glucuronidases in the GI tract convert SN38G back to SN38 in the intestinal tract, which is thought to be the rationale for the delayed onset diarrhea that we see in patients between 2 and 14 days after the dose. Traditional Irinotecan has a half-life of 6 to 12 hours, and SN38, the active metabolite, has a half-life of about 10 to 20 hours. Liposomal irinotecan has a much longer half-life because of the liposomal formulation of 67 hours. There are several side effects to monitor patients for after the doses, including myelosuppression, which is mainly neutropenia, alopecia, mucositis, interstitial lung disease, which is rare but serious, increased liver function tests, fatigue, as well as diarrhea, which can be acute within the first 24 hours or delayed between 2 and 14 days after the dose. Some drug interactions that we should watch out for when giving irinotecan include CYP3A4 inhibitors, which can decrease the formation of active metabolites, and then in patients who are homozygous for the UGT1A1*28 allele, these patients are at a higher risk of severe neutropenia. And then, as I alluded to a little bit before in the slides, patients can get irinotecan-induced diarrhea, and this is one of the most common side effects that most patients see. It can include an acute cholinergic diarrhea, and for this we give atropine, typically a dose as a premedication, and then have another dose on hand during the infusion in case the patient experiences cramping during their infusion. And then delayed diarrhea because of the formation of SN38, which is then glucuronidated and then deglucuronidated through the intestinal glucuronidases, which can then lead to SN38 again in the intestine and can cause that delayed diarrhea. Patients need to be treated aggressively with antidiarrheals to prevent dehydration and electrolyte abnormalities. And then occasionally in pediatric patients, there has been consideration given to giving patients cephalosporin prophylaxis, but this is definitely not commonly done in adult patients. And I want to thank you for watching today. If you have any questions for me, please let me know in the comments below, and I will do my best to answer them. Thank you.